Imagine trying to breathe through a tiny drinking straw. Now imagine someone quietly taking that straw away every few seconds. Scary, isn't it? That's exactly how many people describe an asthma attack. The frightening part? Asthma can become life-threatening within minutes if it's not recognized and treated quickly. But here's the good news. Once you understand what's happening inside the lungs, asthma becomes much easier to recognize, assess, and manage. Whether you're a nursing student preparing for exams, a newly qualified nurse, or simply someone wanting to understand asthma better, let's simplify asthma together. Welcome to Nurse IQ, where we make complex nursing topics simple, practical, and unforgettable. Let's begin. Asthma isn't rare. In fact, it's one of the most common long-term respiratory conditions seen in hospitals, GP surgeries, community clinics, schools, and emergency departments. As nurses, we encounter asthma almost everywhere. You might care for a child brought into A&E struggling to breathe, a university student having an asthma attack during sports, a pregnant woman whose asthma has worsened, an elderly patient with pneumonia and asthma, or someone attending a routine asthma review in the community. Asthma doesn't discriminate. It affects children, adults, and older people from all walks of life. The good news? Most people with asthma can live healthy, active lives when it's well controlled. The challenge is recognizing when asthma is becoming dangerous. Let's be honest. Our lungs can be a little dramatic. A tiny bit of pollen floats by. The lungs respond, "Absolutely not! Shut everything down!" Of course, that's not really what's happening, but that's exactly what it feels like for many people with asthma. The airways become overly sensitive and react much more strongly than they should. Understanding why this happens is the first step to becoming an excellent nurse. Let's start with the official definition. Asthma is a chronic inflammatory disease of the airways characterized by variable airflow obstruction and increased airway responsiveness. That sounds like something written to make nursing students panic before an exam. So let's translate it into plain English. Asthma is a long-term condition where the breathing tubes inside the lungs become inflamed and overly sensitive. When exposed to certain triggers, those airways narrow, swell, and produce extra mucus, making it difficult for air to move in and out. Think of asthma as an overprotective security guard. Most people's airways stay calm when they encounter cold air or dust, but an asthmatic airway behaves differently. It overreacts. It treats harmless things as though they're dangerous intruders. That exaggerated reaction causes the symptoms we associate with asthma. Before we understand asthma, let's remind ourselves how normal breathing works. Imagine your respiratory system as an upside-down tree. The trunk represents your trachea, also known as the windpipe. The trunk then divides into two large branches called the right and left bronchi. These branches continue dividing into smaller branches called bronchioles. At the very end are tiny air sacs called alveoli. This is where oxygen enters the bloodstream and carbon dioxide leaves the body. Every single breath follows this pathway. Air enters through your nose or mouth, travels down the trachea, into the bronchi, through the bronchioles, finally reaching the alveoli. Simple. When these airways are open, air flows freely. Breathing feels effortless. Most of us never think about breathing because healthy lungs do their job every second of every day. What happens during an asthma attack? Now imagine this healthy airway suddenly becoming irritated. Three major things happen at the same time. Number one, bronchospasm. The muscles surrounding the airways tighten. Imagine squeezing a garden hose. Exactly the same thing happens inside the lungs. Number two, inflammation. The lining of the airway becomes swollen. Think about accidentally biting the inside of your cheek. Within minutes, it becomes puffy and swollen. The same thing happens inside an asthmatic airway, but because you can't see inside the lungs, it's easy to forget that swelling is happening. Finally, the lungs produce thick, sticky mucus. That mucus occupies the little space that remains inside the airway. Now imagine trying to drink a milkshake through a straw filled with jelly. Not easy. That's why patients often cough. They're trying to clear the mucus and open their airways. So remember this simple rule. Asthma equals tight airways plus swollen airways plus extra mucus. 3 problems, 1 difficult breath. Here's a Nurse IQ memory trick you'll remember during exams. Think of the word TSM. T a tight muscles, S a swollen lining, M a mucus. Whenever you hear the word asthma, immediately think TSM, tight muscles, swollen lining, mucus. If you remember those three things, you'll understand almost every symptom and treatment we'll discuss later. We've now answered one of the biggest questions in respiratory nursing: what asthma is and what happens inside the lungs during an asthma attack. But here's where things become even more interesting. Why do some people develop asthma while others never do? Why can one person cuddle a cat with no problem while another starts wheezing within minutes? And why does cold air, exercise, laughter, or even strong perfume trigger asthma in some people? In part 2, we'll explore asthma triggers, risk factors, signs and symptoms, clinical assessment, and the red flags every nurse must recognize before it's too late. Trust me, you won't want to miss it. Welcome back to Nurse IQ. In part 1, we discovered that asthma isn't simply difficulty breathing. We learned that 3 things happen during an asthma attack. The airway muscles tighten, the airway lining swells, and thick mucus is produced. Remember our Nurse IQ TSWRM: tight muscles, swollen lining, mucus. If you missed part 1, I strongly recommend watching it first because everything we're discussing today builds on that foundation. Now let's answer the question many patients ask: why do I have asthma and what keeps triggering it? One of the biggest myths about asthma is that people are born with it. The truth is a little more complicated because of a combination of genetic and environmental factors. Think of it like baking a cake. You need more than one ingredient. Some people inherit a tendency for their immune system to overreact. If asthma, eczema, or hay fever runs in your family, your risk may be higher. But genetics alone don't always cause asthma. Environmental factors often act as the spark that lights the fire. This explains why 2 siblings living in the same house may not both develop asthma. Several factors increase the likelihood of developing asthma. These include a family history of asthma, eczema, and hay fever. Environmental factors like cigarette smoke, air pollution, and occupational dust are also risks. Childhood infections, premature birth, and obesity can increase risk. Having one or more of these risk factors doesn't guarantee someone will develop asthma, but it does increase the likelihood. Here's something that often confuses patients and even some nursing students. A trigger is not the same as the cause of asthma. The cause explains why a person has asthma. A trigger is what sets off their symptoms. Think of asthma like a smoke alarm. A smoke alarm is useful, but imagine if it went off every time you made toast. That's how sensitive an asthmatic airway can become. Let's look at some of the most common triggers. Pollen. This is why many people experience worse symptoms during spring and summer. Pet dander. It's not actually the fur that's usually responsible, it's proteins found in the animal's skin flakes, saliva, or urine. Cigarette smoke. Smoking irritates the airways and can make asthma significantly worse. Even secondhand smoke can trigger symptoms. Cold, dry air can cause the airway muscles to tighten, making breathing more difficult. Exercise is healthy, but for some people it can temporarily trigger asthma symptoms, especially in cold weather. A simple cold can quickly develop into an asthma flare-up. Traffic fumes, industrial pollution, and poor air quality can all worsen asthma. Perfumes, air fresheners, cleaning products, paint fumes, and aerosols can trigger symptoms in some people. Stress doesn't directly cause asthma, but it can make symptoms worse or trigger an attack in some individuals. Have you ever walked into a shop and someone sprayed half a bottle of perfume? Most people think that's a strong fragrance. Someone with asthma might be thinking, "This is not the day I expected my lungs to start protesting." It sounds funny, but for many people, it's a genuine trigger. Asthma symptoms vary from person to person. Some people have occasional mild symptoms, while others can become critically ill very quickly. Classic symptoms include shortness of breath. Patients often describe feeling as though they can't get enough air into their lungs. Wheezing is a high-pitched whistling sound from narrowed airways, often heard during expiration. Severe asthma may cause wheezing during both inspiration and expiration. Many patients describe chest tightness as someone sitting on their chest or tightening a belt around it. Asthma doesn't always present with wheezing. Some people, especially children, mainly have a persistent cough that worsens at night or after exercise. Nighttime symptoms. Frequent waking because of coughing, wheezing, or breathlessness is a sign that asthma may not be well controlled. One of the most important nursing responsibilities is recognizing when a patient is deteriorating. Asthma can worsen rapidly, so early recognition is essential. Mild asthma. The patient speaks normally, has a mild wheeze, slight breathlessness, and responds well to reliever medication. In moderate asthma, breathlessness increases, making long walks difficult. You'll notice more frequent coughing and a more noticeable wheeze. Your respiratory rate also increases. Now we're entering emergency territory. The patient can't complete full sentences. They're sitting upright using accessory muscles. Heart rate is up, oxygen is falling. The patient looks anxious, distressed. These patients need urgent medical assessment and treatment. These are the red flags every nurse must recognize immediately. Silent chest with minimal or no wheeze due to very poor airflow. Cyanosis with bluish lips or skin. Exhaustion, confusion or reduced level of consciousness. poor respiratory effort, bradycardia, or signs of impending respiratory arrest. Remember this carefully. A silent chest is not a reassuring sign. It may mean that so little air is moving that there isn't enough airflow to produce a wheeze. This is a medical emergency. When assessing any patient with acute asthma, always think ABCE. This structured approach helps you handle life-threatening problems quickly. A. Airway. Is the airway open? Can the patient speak? Are there signs of obstruction? B. Breathing. Assess respiratory rate, oxygen satisfaction, work of breathing, chest expansion, use of accessory muscles, and peak expiratory flow if appropriate. C. Check pulse, blood pressure, capillary refill, skin color, and temperature. D stands for disability. Assess level of consciousness, use AVPU or the Glasgow Coma Scale. Confusion or drowsiness can indicate worsening respiratory failure. E. Exposure. Look for possible triggers such as a rash suggesting an allergic reaction, signs of infection, or environmental factors. Maintain the patient's dignity while completing your assessment. Remember, assessment and treatment often happen at the same time. If a patient is critically unwell, don't delay treatment while trying to complete every assessment step. We've learned why asthma develops, the common triggers, how to recognize worsening symptoms, and how to assess a patient using the ABCDE approach. In Part 3, we'll bring everything together by exploring asthma investigations, inhalers and medications, emergency management, nursing interventions, patient education, discharge planning, and exam tips that every nursing student should know. You're doing brilliantly so far. Take a short break, grab a drink, and join me in Part 3, where we'll focus on helping patients breathe easier and where nurses make one of the biggest differences. Welcome back to Nurse IQ. If you've been with me through Parts 1 and 2, you're doing an amazing job. We've learned what asthma is, why it happens, the common triggers, and how to recognize when a patient is deteriorating. Today, we're bringing everything together. We'll cover investigations, medications, inhalers, emergency management, nursing care, patient education, and some exam tips that could help you both in clinical practice and your nursing assessments. Let's get started. One question nursing students often ask is, can asthma be diagnosed with just one test? The answer is no. Asthma is diagnosed using a combination of the patient's history, physical examination, and appropriate investigations. Let's look at the key diagnostic steps. A good history is one of your most valuable assessment tools. Ask about breathlessness, wheezing, and chest tightness. Inquire about nighttime symptoms and after exercise. Check for seasonal patterns, family history, and smoking. Also ask about occupational exposure and hospital admissions. Finally, current medications and previous ICU stays. Never underestimate the importance of asking good questions. Patients often give you the diagnosis before any test is performed. Let's assess the patient. Check respiratory rate, oxygen satisfaction, and work of breathing. Then, assess chest expansion and listen for a wheeze. Accessory muscle use. Also check speech, heart rate, and consciousness. This simple device measures how quickly a person can blow air out of their lungs. Lower readings may indicate narrowed airways, but always interpret the result in the context of the patient's usual best reading and the overall clinical picture. Spirometry measures how much air a patient can breathe out and how quickly. It helps identify airflow obstruction and whether it improves after bronchodilator medication. This test is key for managing asthma effectively. Other investigations may be needed for asthma. This includes fractional exhaled nitric oxide or FeNO, allergy testing, and a chest X-ray. Blood tests are also used when indicated. These help create a full picture. If you've ever looked inside an asthma patient's medication bag, you might wonder why there are so many different inhalers. The reason is simple. Different inhalers do different jobs. Reliever inhalers. Reliever inhalers contain medicines that relax the muscles around the airways, helping them to open more quickly during symptoms. Patients often describe them as their rescue inhaler. They help relieve symptoms, but they do not treat the underlying inflammation. Preventer inhalers. Preventer inhalers are used regularly to reduce airway inflammation and help prevent future symptoms. They're most effective when taken consistently, even if the person feels well. This is one of the biggest teaching points for nurses. Many patients stop taking their preventer inhaler because they feel better, but that's often when it's doing its job. Combination inhalers. Some inhalers contain more than one medication, combining anti-inflammatory treatment with a long-acting bronchodilator to improve symptom control in appropriate patients. Spacer devices help deliver medication more effectively into the lungs and reduce the amount that stays in the mouth or throat. They can be particularly useful for children or adults who struggle with inhaler technique. Let's be honest, using an inhaler properly is harder than it looks. Some people spray the medicine into the air, some press it after they finish breathing in, and some seem to be trying to perfume the room rather than treat their lungs. That's why checking inhaler technique should be part of every asthma review. Now let's discuss what every nurse must know, recognizing and responding to an acute asthma exacerbation. If a patient presents with severe breathlessness, they require prompt assessment and timely treatment. Management should always follow local protocols and involve the appropriate senior clinicians. Let's review the immediate priorities for an asthma attack. First, perform an ABCDE assessment. Sit the patient upright if tolerated. Monitor oxygen saturation. This is crucial. Administer oxygen if clinically indicated. Assist with prescribed bronchodilator therapy. Escalate concerns promptly to the medical team. Good assessment leads to better outcomes. Remember, reassessment is just as important as the initial assessment. A patient's condition can improve or deteriorate within minutes, so monitor your patient closely and reassess frequently. This ensures better outcomes. Asthma management isn't just about inhalers. Nurses play a vital role before, during, and after asthma attack. Let's discuss continuous assessment for asthma patients. Monitor respiratory rate, oxygen saturation, and pulse. Check blood pressure, work of breathing, and ability to speak, and assess their response to treatment. Good documentation protects both the patient and the healthcare team. Record assessment findings, observations, and interventions. Also record medication administered, patient response, and escalation of care. Don't forget education provided. One of the most rewarding parts of nursing is empowering patients. Let's cover correct inhaler technique. Hold it upright, exhale, press, and inhale slowly. Adhere to your medication schedule and avoid triggers. Recognize worsening symptoms and seek urgent help. Use your action plan. An informed patient is a safer patient. Although many people live well with asthma, poor control can lead to serious complications. These may include frequent emergency department visits and hospital admissions. It can also lead to reduced quality of life and missed school or work. In severe cases, respiratory failure can occur. Rarely, it can even lead to death. That's why proper management is crucial. Students often confuse asthma with COPD, but there are important differences. Asthma often starts in childhood or early adulthood, and its symptoms can vary from day to day. The airflow obstruction is often reversible, and it's frequently associated with allergies. COPD usually develops later in life, often linked to smoking or environmental exposure. Airflow limitation in COPD is persistent, and symptoms progress gradually. Remember, patients can have features of both asthma and COPD. Diagnosis should always be based on a full clinical assessment. Section 7, Nursing IQ Exam Tips. Here are some high-yield points that frequently appear in nursing exams and clinical assessments. Remember TSM, T, tight airway muscles, S, swollen airway lining, M, mucus production. Remember ABCDE, always assess systematically. Never ignore these asthma red flags. Inability to speak in full sentences, increasing exhaustion, silent chest, reduced level of consciousness, cyanosis, worsening respiratory distress despite treatment. Recognizing these signs early can save lives. Let's put everything together. You're working in the emergency department. A 24-year-old patient arrives, sitting upright, speaking only in short phases. They're using accessory muscles to breathe, have widespread wheeze, and say their reliever inhaler hasn't helped. What should you do? Think ABCDE, call for help early. Assess, monitor, administer prescribed treatment according to local protocols, and keep reassessing. Don't wait for the patient to become exhausted before escalating your concerns. This is exactly why structured assessment is so important. Let's recap today's key learning points. Asthma is a chronic inflammatory disease of the airways. During an asthma attack, the airway muscles tighten, the lining swells, and mucus production increases. Common symptoms include wheezing, breathlessness, chest tightness, and coughing. It's critical to recognize red flags like a silent chest, inability to speak in full sentences, or reduced consciousness. Always use the ABCE approach for assessment. Support prescribed treatment, monitor closely, educate patients, and escalate concerns promptly. This ensures better outcomes. If there's one message I want you to remember, it's this. Patients don't remember every medical term you use, but they always remember how safe you made them feel. As nurses, we don't just administer medications. We recognize deterioration, educate patients, provide reassurance, and sometimes make the difference between a patient recovering safely at home and becoming critically unwell. Keep learning. Keep asking questions. Keep practicing your assessment skills. Every patient you care for will teach you something new. If you found this masterclass helpful, please like the video, subscribe to Nurse IQ, and share it with your classmates or colleagues. Together, we're building a community of knowledgeable, compassionate, and confident nurses. In our next episode, we'll explore pneumonia, how to recognize it, assess it, manage it, and understand the nursing care every student should know. I can't wait to see you there. Until next time, keep learning, keep caring, and stay curious.